Good morning, everyone, and a very warm welcome to E for Endometriosis' first free quarterly Zoom session for 2026. Thank you for taking time out of your Saturday to be here with us. Whether you are joining as a patient, caregiver, healthcare professional, ally, or someone who simply wishes to understand endometriosis better, we are grateful to have you in this space. My name is Yasmin, and I'm your MC for today. A little background about myself. I have struggled with endometriosis since I was a teen without knowing that it was endometriosis. Many of us simply accept the debilitating pains, heavy flows as if it's normal, and that's what I did for decades. In fact, my cramps used to be so painful that occasionally I would feel like passing out, but yet I went to work like nothing was happening, right? I had my first surgery in 2011 at the age of 37, and that was only because it was when my hubby and I were trying to have kids and we were not able to when I was around my mid 30s that I finally went to see gynecologists. And that's when I realized, oh, I have endometriosis. And so the first surgery was done at 37 in 2011, and it was already in a very bad state. In fact, my doctor told me how there were so many adhesions that organs that were supposed to be at the back of my body were being weighed down and pulled down to the front of my body because of the many adhesions. And after the first surgery, we did IVF a year later. Well, that didn't work for us, and we just accepted it as that because once was enough. But however, a few years after the first surgery, I had strange symptoms starting again. So things like I started having dark brown spottings that became like almost a daily incident. Dark brown spottings. I had this pain on my left side that was like a strange pulling sensation again. And it became so bad that I couldn't sleep on my left anymore. And then I also had this inexplicable feeling that something was at the base of my spine. Okay, so long story short, went to see a doctor again, this time in 2022. So about 11 years after my first surgery, I went for my second surgery. And this time, in addition to removing all the adhesions, my inflamed fallopian tubes were removed as well. Now, it was at this second surgery that my gynae informed me that I was close to 80% close to menopausing. I mean, my periods had already started dwindling over the past couple of years leading up to 2022. But it was during the surgery that the doctor could see that, yeah, the ovaries had shrunk, and also from my blood tests and things like that, that, yeah, I was on the way, well on the way to menopausing. And to be honest, I was very happy to hear that. For someone who had to spend decades dealing with such intense pains and so many issues due to endometriosis, trust me, going through menopause for me was good news and it was not a big deal at all. I mean, of course, I had hot flushes and some brain fog, at times, things like that. But honestly, it really was a walk in the park and good news for me. Okay. I do not have any symptoms of endometriosis for me anymore. Now, I menopaused when I was 48. It's earlier than my mom and my aunts, and I don't know if endometriosis led to my menopause coming in earlier, but I think this is a good segue to today's topic, which is, can endometriosis cause menopause before 40? This is something many wonder about, especially those who have gone through repeated surgeries, hormonal treatments, recurring cysts, fertility concerns, or changes in their body that they do not fully understand. So today, we hope to have a grounded and compassionate space to better understand perimenopause, early menopause, medical menopause, and endometriosis after menopause. A little note about E for endometriosis, especially for those who are new to us. E for endometriosis is a ground up movement dedicated to awareness, education, and community support for those affected with endometriosis. Our quarterly Zoom sessions are part of our free community education initiative. These sessions are created to make information more accessible so that patients, caregivers, and the wider community can feel more informed, supported, and less alone. We believe that knowledge is power, and choosing to be enlightened empowers us to make informed decisions, ask better questions, and advocate for ourselves and the people we care about. Before we begin, a few housekeeping notes. First, please keep your microphone muted throughout the presentations. Second, today's session will be streamed and recorded for E for Endometriosis YouTube channel. This allows the community to revisit the session anytime they need a refresher and to share it with others who may benefit from the information. You may also submit your questions anytime during the presentations. We will be using Pigeonhole Live for the Q&A segment later. Please scan the QR code shown on screen. Can we have the QR code up on the screen, please? Yes, so please scan the QR code shown on the screen to submit your questions, and you can submit them anytime throughout the event. And we will try our best to address as many as we can during the Q&A segment. Lastly, please note that today's session is for general education and awareness only. It is not a substitute for personalized medical advice. If you have specific concerns about your symptoms, treatment options, fertility treatments, hormones, menopause, please consult your own doctor or healthcare professional. So our session will run from now till about 1 p.m. We will begin with a 30-minute presentation by Dr. Michelle Lim Hui Ping, followed by a 30-minute presentation by Ms. Diana Tan. After both presentations, we will move to the Q&A segment using Pigeonhole Live. Okay, and now it is my pleasure to introduce our first speaker, Dr. Michelle Lim Hui Ping. Dr. Michelle is a consultant obstetrician and gynecologist at Noble Obstetrics, Gynecology, and Minimally Invasive Surgery Center. She specializes in general obstetrics, gynecology, and minimally invasive surgery, with extensive experience in advanced laparoscopic surgery and the management of endometriosis, adenomyosis, fibroids, and ovarian cysts. With more than 15 years' experience, Dr. Michelle is deeply committed to patient-centered care, combining clinical expertise with empathy and a strong focus on safety. Today, she will help us to understand the medical and hormonal aspects of endometriosis and how it may relate to perimenopause, early menopause, and menopause before 40. Please join me in welcoming Dr. Michelle Lim Hui Ping. Dr. Michelle, over to you.
Thank you, Yasmin. Let me start by sharing my screen. Just to confirm that we can all see my presentation slides before I start.
Yes.
Okay, just give me a moment. Okay, good. Okay, all right. So sorry about that. Some technical issues. No matter how many times I do Zoom presentations, it's always a problem for me. Okay, so good morning, everyone.
Dr.
Thank
Michelle,
you.
we still see the video from Zoom.
Oh, you can see the presentation slides?
We see the presentation slides, but we also see the video of the speaker.
Video of the speaker. You mean of me?
Yes.
Oh, is it blocking your view though?
A little bit, yeah.
I see. Is it better now?
Nothing has changed.
Hmm. I'm not really certain how
Dr.
to.
Michelle, maybe
Yeah.
you can, there is like a icon at the top of your face.
Yeah.
You can point it to one dash. There's one dash at
Yeah.
further up.
Further up.
Yeah, there is like
This
a
one?
few yeah.
Okay.
If you can maybe click on the one that is with the very first one, you can move your cursor,
Mm-hmm.
and then try to move it. Currently, you are looking at two, what they call this? Hold on,
2 bars.
two bars, right?
Two
Then there
bar.
is this one bar.
Yeah, slightly to the left.
I'm slightly to
Um,
the left. You mean this? Show
Yeah,
me.
yes,
click
yes,
on
yes,
that.
Okay.
yes, yes.
Click on that and then is it okay now?
Yes, yes,
Okay.
super.
Oh, good.
Yes.
Oh my God. Okay, I'm so sorry, everyone. Okay, I'll start now. Okay, so good morning, everyone. Thank you to Namira and E for endometriosis for having me here today to share a topic relevant to endometriosis that we are increasingly cognizant of. So, like Yasmin just shared, actually, I think your experiences with adolescent phase symptoms, your subsequent struggle with fertility, and then your transition towards potentially slightly earlier menopause, and even looking forward to menopause symptoms is really not an uncommon presentation or something that I have guided many patients over the years. So, can endometriosis cause menopause early and before 40? I think in today's era of greater health literacy and self-advocacy, we are not just seeking information on symptom control, but something that I'm a great advocate about, which is self-care, preserving hormonal health, quality of life, and well-being across our lifespan. So I think Yasmin has given an introduction about myself. Okay, I'm Michelle. My clinic is at Nobel Obstetrics, Gynae and MIS Center. We're located at Mount E Novena. Prior to transitioning to the private sector, I was previously working at the minimally invasive surgery and endometriosis unit in KK, and I did my international surgical fellowship in Taiwan in advanced MIS and endometriosis surgeries. I see all women with OBGYN concerns, but I do specialize in managing patients with endo and performing advanced MIS type procedures. Before discussing menopause and ovarian aging, I thought I'd just start by setting the scene, reintroducing what endometriosis is, its prevalence, and our evolving understanding of why this topic matters. I think we all know what endometriosis is. It's defined as a chronic inflammatory condition which in tissues similar to the endometrium, that's where it derives its term from, also known as the menses lining. It's found outside our uterus, most commonly involving the ovaries, the pelvic peritoneum, and surrounding pelvic structures. It is one of the most common chronic gynecological conditions worldwide, affecting approximately 10 to 20% of women, oftenest diagnosed in our reproductive years. Increasing evidence suggests that the disease actually begins way earlier, with endometriosis identified in a significant proportion of adolescents and teens, presenting with severe painful cramps or even chronic pelvic pain, and sometimes in atypical symptoms like school absenteeism or bowel symptoms, vomiting, and fainting spells. Although traditionally considered a disease of the reproductive age women, endometriosis can also persist through the climacteric and sometimes even in the postmenopausal years. So
Sorry, Dr. Michelle. The bar this meeting is being live streamed is actually covering the title. Can you just click OK? So sorry, thank you.
Okay. All right, okay. So till this day, the understanding of why endometriosis occurs has yet to be fully comprehended. As early as 1927, the theory of backwards flow or retrograde menses and implantation was proposed, which is still the best and maybe most easily understood mechanism and something that I use to allow my patients to visually understand the condition. It's suggested that each time we menstruate, there is retrograde menstrual bleeding, with all of these menses lining cells flowing backwards and implanting on the tissues inside our pelvis. So these refluxed and abnormally deposited cells trigger bleeding inside our abdomen during each menses. So cycle on cycle, year on year, can imagine the repeated inflammation, pain, and growth of these cells leads to pain, scarring, and a lot of toxicity to surrounding tissues, including our ovaries. There are other theories, including like blood or lymphatic spread, and the possibility that some of us have an altered immune system that doesn't clear these ectopic endometrial cells, and also a genetic role, where it's postulated to be inherited as a complex genetic trait. It's not uncommon for patients to have a family history of endometriosis if you dive down into it. Endometriosis is notorious for causing chronic pelvic pain and infertility, often significantly impacting our quality of life and reproductive outcomes. That has been heavily emphasized. But there's increasing awareness that it contributes towards accelerated ovarian aging, reduced ovarian reserve, and the premature compromise of our endocrine function. As such, contemporary management is shifting not only to symptom control and fertility treatment, but also the preservation of long-term ovarian and hormonal health. Why is this topic important, and why the question of whether endometriosis can cause early ovarian insufficiency or menopause is because many of us with endometriosis are diagnosed during our reproductive years, where fertility preservation, long-term hormonal health, and quality of life are major concerns. There's a lack of awareness that the impact of endo has an ovarian functional decline beyond fertility, with effects on our bone density, cardiovascular and cognitive health, sexual well-being, and overall quality of life. Both endometriosis as a disease itself, as well as its treatments, particularly repeat ovarian surgery, may affect our ovarian reserve and potentially increase the risk of earlier ovarian insufficiency or menopause in some of us. As we are increasingly delaying childbearing, understanding this relationship is very important to counsel regarding fertility planning, sometimes timing of surgery, and individualize our treatment strategies. Amid increasing recognition of this, we are beginning to see a shift from a predominantly reactive model of care towards one that is more preemptive and proactive in terms of preserving ovarian health. So how does endometriosis affect ovarian reserve? It is thought to occur through several interconnected mechanisms. Firstly, endometriotic ovarian cysts. These are fluid-filled pouches within our ovaries that contain actually oat blood. The previous name or nickname for it was chocolate cysts, because actually during surgeries, when we remove these cysts, it contains years and years of retrofluxed menstrual type bloods. So this actually is very toxic to the healthy ovarian tissue, and it causes this by chronic inflammation, oxidative stress, distortion of the normal ovarian architecture, and this results in depleting of our remaining egg pool as well as the quality of our eggs. In addition, surgical treatment of ovarian endometriotic cysts, although often necessary, if improperly performed, may inadvertently remove healthy ovarian tissue alongside the cyst wall, further contributing to a drop in ovarian reserve. Recurrent disease further compounds this, creating a continuum of inflammatory injury and increasing the likelihood of needing repeat surgery, both of which may accelerate ovarian compromise with time. What is ovarian reserve? It actually refers to the quantity and to some extent the quality of the eggs remaining in our ovaries. Unlike many other cells in our body, we are born with a fixed number of eggs which naturally decline with age. Besides its implication on reproductive potential, the ovaries are endocrine organs that produce hormones like estrogen and progesterone that influence our menstrual function, bone, heart, cognitive health, and overall hormonal well-being. It's most commonly assessed using blood levels of anti-Mullerian hormone or AMH, together with ultrasound assessment of the antral follicular count, both of which provide an estimate of the remaining egg pool. Premature ovarian insufficiency, or POI for short, is a clinical condition characterized by the loss or significant decline of normal ovarian function before the age of 40. It's characterized by impaired or absent ovulation and hence irregular periods, reduced estrogen production, and other derangements in hormone levels associated with ovulation, preceding complete stopping of ovulation. It's medically defined as little or no periods for at least 4 months and a follicular stimulating hormone or FSH level of more than 25. FSH is a hormone that's produced by the brain that acts like a messenger signal to the ovaries. Its role is to stimulate the ovaries to grow and mature eggs every month. So in women with good, healthy ovarian function, the ovaries respond well to this signal, and so FSH levels won't be high. But when the ovaries have fewer remaining eggs and or are not functioning well, such as in premature ovarian insufficiency, the brain tries to overcome this by stimulating and producing high levels of FSH. So what is the real risk? In this recently published study, data from 279,000 women in 5 cohort studies spanning UK, Australia, Japan, Sweden between 1996 and 2022 were analyzed. It provided robust evidence that women with endometriosis have a 7-fold increased risk of surgical menopause and are less likely to experience natural menopause. Women with endometriosis also tend to reach menopause earlier and are more likely to experience premature or early menopause, both caused by surgery or because of disease alone. They are also shown to be 1.4 times more likely to develop spontaneous premature ovarian insufficiency. So to answer our opening question, can endo cause menopause before 40? Yes, it may. Endometriosis may contribute to slightly earlier natural menopause in some of us. Repeat ovarian surgery or obviously removal of the ovaries for treatments can lead to earlier or surgical menopause. But at the end of the day, it's important to have balanced information and remember that actually many women with endometriosis still undergo menopause at the usual age. So should we monitor or can we monitor for premature ovarian insufficiency? So like we mentioned, while women with endo may have a slightly increased risk of earlier menopause in some circumstances, menopause is still considered a natural life transition, and most of us don't undergo premature menopause. At present, there is no role for routine screening or prophylactic testing for early menopause in women with endo, but instead we should focus on being aware or attentive to symptoms that may suggest declining ovarian function or menopause occurring earlier. For example, changes in our menstrual patterns. Sometimes our cycles are coming longer, maybe the flow is getting less and we're skipping cycles in between. Vasomotor symptoms, hot flashes, sleep disturbance. Patients always tell me they have insomnia, early morning awakening, or reduced fertility. Assessment of ovarian reserve, such as AMH or antral follicular count, sometimes can be useful, but they are actually more valuable in the context of reproductive planning rather than predicting the timing of menopause. In select women, they can help guide counseling of reproductive timing, consideration of fertility preservation, earlier investigations of fertility, and realistic expectation setting. It's also important to recognize some specific risk factors that may increase the risk of premature ovarian insufficiency, like repeat ovarian surgery, bilateral both sides endometriotic cysts, reduced ovarian reserve, or a genetic predisposition. At the end of the day, I always feel management should aim to avoid excessive surveillance leading to unnecessary anxiety, but balance symptom control with preservation of long-term hormonal health. So just to introduce some of the commoner ovarian reserve markers, some of us may have heard about these before: antral follicular count and anti-Mullerian hormone, AFC, and AMH are widely used biomarkers to assess ovarian reserve, representing ultrasound and hormone indicators of follicle quantity. AFC refers to the number of follicles measuring 2 to 10 millimeters in diameter in the ovaries at the start of the menstrual cycle, while AMH is a protein that is produced by the antral or leader follicles and serves as a surrogate marker for ovarian reserve. In general, higher AFC and AMH correlate with a larger remaining ovarian reserve, while conversely lower levels may suggest diminished ones. So as we've just mentioned, there's no established role for routine testing to predict premature ovarian insufficiency because there are no universally accepted cutoffs, guidelines, or validated post-test management pathways. And also, although low levels on tests of ovarian reserve likely reflect reduced quantity, it may not always correlate to earlier ovarian shutdown or menopause. But once again, these may enact a valuable role in reproductive counseling and planning. If you establish a baseline ovarian reserve and monitor trends over time, it can actually help identify some of us with accelerated decline and inform on timing of conception attempts, perhaps with some urgency. Prompt referral to reproductive medicine specialists to discuss fertility preservation, like egg freezing, which I will touch a little bit on later. In surgical settings, pre-op assessment of ovarian reserve can also help guide us depending on our patient's reproductive needs, on whether to proceed with fertility treatments first or before surgery where appropriate, and predict those who may benefit from pre-op egg freezing. Symptoms of POI can vary from person to person and may gradually develop or they can suddenly come on. Common symptoms include irregular or absent periods, hot flashes, night sweats, sleep disturbances, feeling tired, mood lability, vaginal dryness, difficulty concentrating, or what we term brain fog, and reduced libido. Symptoms can sometimes also be very confusing, as they may be overlapped with those of endometriosis like bloating or chronic fatigue, or if we may be on hormone treatments that affect the pattern of our periods or cause us some of these similar-ish side effects. At the end of the day, what matters most is how they affect our quality of life, so there's no harm in discussing them with our doctors. Early conversations can lead to earlier identification, counseling, support, reassurance, and appropriate care when needed. POI affects far more than fertility alone. Because the ovaries produce hormones such as estrogen that affect or influence so many organs throughout our body, early decline in ovarian function can have widespread physical and emotional effects. Beyond reproductive health, it affects long-term well-being. Bone density may decrease more rapidly, increasing the risk of osteopenia, osteoporosis, and related fractures. Cardiovascular health may also be impacted with higher risk of cholesterol changes, high blood pressure, and heart disease with time. Some of us may also experience difficulties with concentration, memory, mood, or emotional resilience, while others notice changes in skin elasticity, hair quality, and overall energy levels. The emotional impact can be equally significant, particularly for women who were not expecting menopause so early, or perhaps are still considering future fertility. Some of them may even have presented with plans to start conceiving. With timely recognition, appropriate hormone treatments, lifestyle measures, and supportive care, many of these effects can be reduced and long-term health protected. As there's no reliable manner that can predict in whom of us endo will cause premature ovarian insufficiency, the focus should be on prevention and protecting our ovarian health over time. One important factor we can control is avoiding unnecessary or overtly aggressive ovarian surgery, especially for ovarian cysts caused by endometriosis. Surgery is clearly indicated in some situations. For example, when the cysts are huge, there's risk of cyst accidents, they hurt, patients are symptomatic, ultrasound or MRI features show a suspicious appearing cyst, which would mandate us removing the cyst for biopsy. Sometimes, if endometriosis affects fertility, we can have tubal distortions or pathology, and we might need to undergo surgeries for those. But whenever surgery is performed, I always feel that it should be done carefully with preservation of egg and ovarian function in mind. Increasingly, we recognize that the type and the way that surgery is performed, as well as the experience and exposure of the surgeon, can make a meaningful difference to future ovarian reserve and reproductive options. Medical hormone suppression, particularly after surgery, is paramount in helping reduce disease recurrence and the need for repeat ovarian surgeries, which are a major contributor to the loss of ovarian reserve. By minimizing ongoing inflammation, cyst recurrence, and repeated surgical damage to ovarian tissue, long-term medical treatment may therefore play an important role in preserving ovarian function and reducing the risk of early ovarian insufficiency. So careful selection of who should undergo surgery. It should be undertaken judiciously as surgery may adversely affect ovarian reserve. Specific indications we mentioned, symptoms that are refractory, large cysts with suspicious features. Careful consideration of the woman's future fertility plans together with thorough pre-op counseling regarding potential reproductive implications is essential. If surgery has to be performed, especially for an endometriotic ovarian cyst, cystectomy, which means complete removal of the ovarian cyst, is recommended over drainage and coagulation, as it's associated with lower recurrence rates and superior long-term improvement in pain symptoms. Fertility-preserving surgical techniques are essential and include meticulous tissue handling, be gentle, careful identification of correct dissection planes to minimize stripping of normal healthy eggs, and strategies to reduce bleeding while preserving ovarian tissue. Excessive electrosurgery, which means we use electricity to burn tissues and allow for stopping of bleeding, should be avoided with alternative hemostatic approaches like suturing or sewing, or use of hemostatic sealants preferred where appropriate. By meticulous dissection, the amount of bleeding is minimal and hence there's less requirement of the need to stop the bleeding, which also saves time and reduces the duration of the surgery. I always say slow is actually fast. My personal practice is not to use any electrosurgery during ovarian cyst removal at all, which is actually possible by careful cyst removal and use of suturing and said hemostatic agents. Sorry. So my personal, the first video is that of a laparoscopic ovarian suturing, which is something I routinely perform after careful removal of endometriotic cysts in patients of all ages to preserve ovarian reserve. There are also specific suturing techniques where we reduce tissue handling and traction to minimize mechanical trauma to eggs, superficial approximation rather than full thickness bites to reduce egg entrapment and restoring normal ovarian anatomy without excessive distortion. The next video showcases a patient with a large 16 centimeter endometriotic cyst. Prior meticulous stripping of the cyst and careful handling meant that there was minimal bleeding, and I used a special hemostatic agent that also has tissue sealing properties. Application of the agent was very useful because it stopped any superficial bleeding and helped to kind of glue the ovarian tissue, restore the anatomy, and minimizing the need to burn or damage the ovary. Medical treatment for endometriosis is well established as an effective strategy for post-op suppression. In fact, it is something I heavily emphasize to my patients as it can significantly reduce post-op recurrence and reactivation rates. However, the role of prolonged medical suppression just for the purpose of ovarian preservation is not really defined as yet. Nonetheless, there's biological rationale that suppression of ongoing inflammation, cyclic bleeding, scarring, and progressive distortion of pelvic anatomy can help press pause on disease progression and potentially reduce cumulative reproductive damage. Needless to say, POI effectively shortens our reproductive window, and as fertility potential can decline very unpredictably, discussions regarding family building plans and timing of pregnancy should begin early in the course of endometriosis care. Some of us who may wish to delay childbearing or who are at higher risk of reduced ovarian reserve, timely exploration of fertility preservation options like egg or embryo freezing should be initiated. Egg or oocyte cryopreservation or freezing is the most widely described fertility preservation strategy in endometriosis, although there isn't any universal consensus regarding patient selection or optimal timing. It's increasingly considered in women at risk of progressive decline in ovarian reserve due to disease activity or anticipated surgical intervention. Published studies and expert opinions suggest that some of us who may particularly benefit are if we have predictors of reduced ovarian reserve, such as age more than 35, low AMH or AFC, bilateral ovarian endometriomas, history of recurrent ovarian surgery for endometriomas, or sometimes before planned ovarian surgery if our anticipated likelihood of post-op spontaneous conception is low. In Singapore, EEF or elective egg freezing is permitted for women aged 21 to 38. Embryo freezing or cryopreservation is generally less commonly utilized than egg freezing. Embryo freezing is highly effective, it's established, but the drawback is that it requires fertilization with sperm and therefore involvement of a male partner, which may introduce ethical, emotional, or legal considerations regarding embryo ownership and disposition in the event of relationship breakdown or changing reproductive intentions. After surgery for endometriosis, monitoring for recurrence should focus on ongoing symptoms, clinical review, and selective imaging rather than routine repeat investigations alone. Patients should be reviewed for return or worsening of pelvic pain, dysmenorrhea, bowel, or urinary symptoms because recurrence can be both symptomatic and progressive. Pelvic examination and ultrasound can be useful, especially in women with a history of previous ovarian endometriotic cysts, to assess for recurrences that could increase the likelihood of needing another surgery and potential reduction in ovarian reserve. There isn't any standardized approach, but I would emphasize longitudinal follow-up to ensure compliance to medical suppression and managing our patients' quality of life while being alert to symptoms or findings that may suggest recurrence. Management of women with POI before the age of 40 in the setting of endometriosis aims not only to relieve menopausal symptoms, but also to replace the hormones that would normally have been produced by the ovaries until the natural age of menopause. The goals of treatment are to preserve our bone, our heart, our cognition, sexual health, maintain quality of life, while balancing the potential risk of endometriosis recurrence or reactivation. Menopause hormone therapy, MHT for short, is safe and generally recommended until the average age of menopause, which is approximately 50. The aim is to replace the hormones that would normally have been produced by the ovaries during our reproductive years, rather than just simply treating menopause symptoms alone. As an estrogen-dependent disease, endo symptoms and disease can potentially be aggravated and reactivated by treatment with estrogen. So a careful balance is required to provide essential estrogen while continuing progestins to suppress residual endometriosis and prevent symptom recurrence or reactivation. Regimes include combined hormone treatment with estrogen, which can be administered orally or transdermally via gels or a patch, and progestins or progesterone, which has several formulations with subtleties in side effect profile and can be administered orally, vaginally, or via an intrauterine device. Another recommended hormone replacement treatment option for patients with POI on a background of endo is tibolone. It acts like a combination of estrogen, progesterone, and small amounts of testosterone and has been shown potentially to have a lower stimulatory effect on residual endometriosis. Choice of therapy should be individualized according to each patient's symptom profile, previous disease severity, their surgical history, cardiovascular or thrombotic risk factors, and patient's preference. In general, transdermal options for estrogen are favored because of their lower thrombotic risk profile and more physiologic hormone delivery. The lowest effective dose that adequately replaces estrogen and controls symptoms should be used. So to just bring these concepts into a more practical and relatable context, I'll just go through a couple of common clinical scenarios. This first patient is a 19-year-old young lady who presents actually with her mom for gradually worsening abdominal bloating. She's seen her GP and ultrasound unexpectedly revealed a large 16-centimeter ovarian cyst consistent with an endometrioma. On further history taking, she shares that she's always experienced painful menstrual periods, but had assumed her abdominal enlargement was simply due to weight gain. On examination, there's a large palpable abdominal mass with mild tenderness. This case highlights how endometriosis in adolescents and young women may be under-recognized or normalized for years, particularly when symptoms such as painful periods are dismissed as normal or expected. It also illustrates how ovarian endometriomas can sometimes grow significantly before diagnosis, emphasizing the importance of awareness, timely evaluation of persistent symptoms. There's often a complex balance required in managing young women with ovarian endometriotic cysts. A large painful endometrioma will require surgery for symptom relief and improvement in quality of life, but surgery itself must be performed thoughtfully and expertly performed to minimize inadvertent loss of healthy ovarian tissue and preserve future fertility potential. Techniques such as careful cystectomy with ovarian-sparing principles are crucial, particularly in young patients who may still desire future pregnancy. It's also important to emphasize that endometriosis is a chronic and potentially recurrent condition, especially in younger women. Post-op medical suppression is paramount to reduce recurrence and potentially minimize the need for repeat surgery. I usually spend a lot of time to allow my patient and carer to understand the indication and safety of such treatments, and this sometimes may require more than a single consult. Longitudinal follow-up is equally important, with ongoing review of symptoms, ovarian health, menstrual well-being, and reproductive goals over time. Counseling remains central throughout care and to provide comprehensive and honest information while avoiding unnecessary fear or catastrophizing, especially in young patients and their caregivers. The next patient represents another very common presentation encountered in endo care, a 34-year-old lady with a history of endometriosis and ovarian surgery in her 20s, who unfortunately defaulted follow-up and didn't really recall being advised to take long-term medical suppression. She now presents for preconception assessment after recently getting married and is hoping to conceive. An ultrasound demonstrates small bilateral recurrent endometriotic cysts, while ovarian reserve testing shows a low AMH and reduced AFC. So this case illustrates an important presentation seen in women with long-standing endometriosis, highlighting the long-term and often silent impact endo can have on ovarian reserve and reproductive lifespan. Although her recurrent cysts are relatively small and not currently causing major symptoms, her fertility potential may already be time-sensitive due to both age and diminished ovarian reserve. Management now shifts towards prompt fertility optimization. This is also a situation where restraint in surgery is critical. Repeat ovarian surgery for small recurrences may further compromise ovarian reserve and potentially worsen fertility outcomes. Given her age and reduced ovarian reserve, she should be advised not to delay attempts at conception, with early referral to a reproductive medicine specialist for counseling regarding fertility potential and discussion of assisted reproductive options where appropriate. The final example is a 38-year-old lady with a history of endo and previous surgery. She now presents with irregular menstrual cycles, sleep disturbance, mood changes, and intermittent hot flashes that are severely affecting her quality of life. Further evaluation shows elevated FSH levels consistent with premature ovarian insufficiency. This case highlights how some women with endo can present later in life not with pain or fertility concerns, but symptoms of early estrogen deficiency and premature ovarian insufficiency. For many of us, the diagnosis can be emotionally challenging, particularly where symptoms are initially attributed to stress, aging, or lifestyle factors. Management should begin with holistic counseling regarding the diagnosis, the impact of estrogen deficiency on bone, cardiovascular, cognitive, and sexual health, and the role and safety of menopause hormone therapy. The focus of care now shifts towards restoring quality of life, protecting long-term bone, heart, cognitive health, and balancing symptom control against the theoretical risk of reactivating residual endometriosis. Treatment includes aiming for physiologic replacement of hormone deficiencies and can include either continuous combined hormone therapy or tibolone, continue until the natural age of menopause, which is around 50, with individualized reassessment after. Care should not end after initiating therapy. These patients benefit from longitudinal follow-up with ongoing review of symptoms, side effects, bone health, cardiovascular risk factors, and possible recurrence of symptoms. In closing, while most women with endometriosis will still experience menopause at the natural age, there is increasing recognition that some of us may face earlier decline in ovarian function or even premature ovarian insufficiency. The key is not fear, but awareness, recognizing symptoms early, seeking timely evaluation, and adopting a proactive rather than reactive approach to care. Management of endo should always balance symptom control, protection of ovarian function, and future fertility goals. Through thoughtful medical therapy, judicious surgical decision-making, specific surgical techniques, and appropriate counseling, they all play an important role in reducing long-term impact to ovarian reserve and endocrine function. At the same time, if POI does occur, early diagnosis and appropriate hormone replacement therapy are essential not only for symptom relief, but also for long-term bone, heart, cognitive, and overall health. Ultimately, the goal is to empower all of us with knowledge, to inform rather than to alarm, so that we can make confident, individualized decisions about our own health, fertility, and well-being across every stage in our lives. And with that, thank you once again to Namira and the members of E for Endometriosis for the kind invitation to share on a less commonly discussed but increasingly recognized aspect of endo. I hope today's talk has highlighted the importance of awareness, balanced counseling, and longitudinal care across our lifespan. I'll be very happy to discuss further at the end of our session today.
Thank you so much, Dr. Michelle, for that wealth of information and very compassionate and clear sharing. Definitely, it's heartening to observe that there's a shift now towards the preemptive focus on long-term ovarian health, as you mentioned, since many of us are diagnosed during our childbearing years. So thank you so much once again for that.
Thank you.
We will hold questions for the Q&A segment later, so everyone please continue submitting your questions through Pigeonhole Live. And now we will move on to our next speaker, who is Ms. Diana Tan. Ms. Diana is a patient advocate who bridges industry, research, and lived experience to improve how evidence is generated and translated into real-world care. She is the founder of Advocates for Advancing Health, focusing on market research, evidence generation, real-world data, and implementation strategies. She also co-founded Menopause Care Alliance, a non-profit patient advocacy group, and serves as an Open Voices patient partner at the Lee Kong Chian School of Medicine, where she collaborates with researchers to co-design studies and translate evidence into practice. Through her work, Ms. Diana continues to advance access, quality of care, and better health outcomes. Today, she will bring an important lens on menopause, advocacy, lived experience, and why conversations like this matter for patients and the wider community. Please join me in welcoming Ms. Diana Tan. Ms. Diana, over to you.
Thank you very much, Yasmin. I think all of that just to say, maybe just all that to say is that I am a patient like you, except that I still am a menopausal patient. And I say the word deliberately, menopausal patient, even though a lot of doctors still say that, it's a natural life stage, it's fine. But all the conditions that come with it are real, and they're debilitating, and they'll impact your quality of life, right? And so I'm quite militant about this. When I first started to get my symptoms, it was so debilitating that I quit my job, I divorced. My cat got diagnosed with anxiety because she was absorbing all that energy from me, right? So it was huge, and I can only imagine how it is for you, because women with endometriosis get gaslighted even more, right? So what I decided to do is I told myself, I have all this background in healthcare, life science. I work with doctors, I work with scientists and researchers. That's my job. I will use my skills to try and give back and do something about, what we're experiencing right now. So when Namira told me, like, hey, do you want to do this presentation? I said, yes. And I thought about, okay, what is it that I can say? Like, looking back, what would have helped me at the start of my journey? And the word control came into mind. So this playbook is to give you back control so that you know how to assess the situation, right? What next steps you can take, what are the right questions you should ask, right? And if the doctor isn't the right one for you, right, how you can spot that and shift direction, right? Now, the thing about endometriosis, and maybe less so with menopause, but even with menopause with Asian women, is that there's not a lot of data, right? So it's really important that we take charge of our health. So today's presentation is all about getting better care. How do we get better care? the idea here, right, is not about you having to be your own doctor. It's not about you having to memorize medical terms. At the end of the day, it's all about these three things. If you're able to do these three things, if it takes a bit of energy, right? If you do these three things, it'll go a long way towards, getting better care. The first thing is, it's important to notice what has changed, because you've lived with endometriosis for such a long time. And then menopause comes in as an extra layer. And menopause in itself is debilitating as well, right? Not with regards to the pain, right? But the migraine attacks, right? Estrogen has been known to impact virtually every part of our body, from our brain to our genital urinary symptoms, right? Debilitating in the sense that you may not be able to do the work that you're supposed to do at work. I found I was diagnosed with ADHD when I was in perimenopause because my symptoms just got so bad that I could not do the work. Things that took me 1 hour took me 8 hours. People would be talking to me and I would get them to repeat. I would get my team to repeat, and they thought that they weren't speaking clearly, but it was because I couldn't process what they were saying, right? So it's debilitating in a different way. So the most important thing for you is to first notice what has changed. Now, once you notice what has changed, you need to record it down. Remember what I said about how there's not a lot of data for you for endometriosis women in Asia. Midlife women navigating perimenopause, menopause is virtually it's negligible, right? So you need to come in and bring your own data to the table. So you need to record the impact. And once you record the impact, this will allow you to ask better questions, ask next steps, and it will also help your doctor a lot, right? So this entire presentation is all about that. Okay, now, why are we doing this? Obviously, you know why, but I just wanted to put out some stats here, right? Just so that you have a clear idea of what the situation is, right? So that, with more information that's pertinent to you, you know what to expect, what are what's the best way forward, right? Now, a lot of, let's say you go to a GP, a primary care, or, another doctor, let's say if you're postmenopausal, they may say, oh, postmenopause, yeah, you probably don't have endometriosis anymore. It's probably just menopausal symptoms, right? But if you look at the first statistic on the left-hand side, 2 to 20% of postmenopausal women, right, have been found to have endometriosis. So this was in a publication, and the doctors don't know why this is happening. It could be because the endometriosis was already there early on. It's just that they weren't diagnosed, or it could have started. It could have started at that age as well. So that the thing is that the key point here for this first statistic is that even postmenopausal, right, endometriosis can be active. So just be aware. The second point is that, right, this was something that Dr. Michelle talked about. There's a high risk of you going into menopause early because you had surgery, or because of the drugs that you took, right? If some of you are on the estrogen suppression drugs, right? GnRH, for example, that gives you higher chance of entering menopause early. And entering menopause early is a big deal. And I'll reinforce what Dr. Michelle said in the later slide. And then, higher chance of ovarian cancer, especially those with chocolate cysts, right? They're really deeply entrenched chocolate cysts. Bearing in mind that the chance of ovarian cancer is still very, very low, right? But this makes it very important for you, and this is where the control comes in, because you then know what to do, right? You then know the importance of follow-up. of pushing your doctor for regular care, right? When is my, how are we going to get this reviewed? What's the schedule, etc. So you can see why, self-advocating, understanding the data, taking control is going to make your life a lot better. It's going to give you peace of mind and be able to sleep better at night. Okay, so endometriosis, menopause, right? Is it the symptoms that I'm feeling, is it endo? Is it menopause? Maybe the better question to ask is, what has changed, right? What is the impact? Because that's a more important question to ask, because it could be both, right? And the thing is that many of the symptoms tend to overlap. Irregular bleeding, brain fog, pelvic pain, for example. Right? There's a lot of overlap in terms of the symptoms. So it could be both. So that's why you need to understand or to ask what has changed and what is the impact. So that's going to be important. There was a study that I came across while I was doing this presentation yesterday. I was scrolling through some of the data and I found this publication done in 2019. And this study was really, really interesting. It spanned 25 years. I think it was in the US and in Greece, so not in Asia. There's practically no data in Asia for endo women in peri or postmenopause. Very insignificant, right? But this data was saying, right, that when you are in the perimenopause stage, right, the endometriosis could actually be very active, right? So if you're in perimenopause and you have very active endometriosis, this is something that, you need to be aware of so that you don't get, you don't get dismissed by physicians, right? You'll be able to, when you record down your symptoms, you record down the impact, you can actually go and get the help that you need. So what the paper found was that I think there was a higher rate, like, they saw a lot more chocolate cysts coming up. They saw also a lot more fibroids happening, right? And then what happened when the women went into postmenopause, right? I think it was then they saw, they didn't see as many chocolate cysts. They saw more adenomyosis, for example, right? So the disease pathology, the condition, right, how it actually shows itself actually changes across time. Now, the thing is that this is not just for endometriosis. It also happens with menopause. So in menopause, in the earlier stage, when I was suffering, I'm still in perimenopause, but in the earlier stages, the brain fog was really severe. I would be looking at a fork, like your spoon and your fork on the table, and it would take me a few seconds to register, oh, I'm looking at a fork, right? So that cognitive fog, that cognitive processes was a real issue for me. And my mood swings, right? I'll be going into the office crying every day, every morning, cry. And I was like telling myself, Diana, this is not professional, right? But the good thing was that, I was always the first person in. And especially when, you're, so I was senior in the organization, and, I felt like, I had to be a bit more professional. But the mood swings and the crying spells were not something that I could control, right? And then once you go into the postmenopausal stage, right, we now have, some good amount of data for Asian women, and we find that it's your bladder issues, your bone issues, that becomes more common, right? You tend to be less, the mood tends to be less of an issue for postmenopausal women, right? So you can see how that, the conditions, the disease pathology changes over time, right? So it's really important, again, right, to make sure that you understand what's changing, that you track what's changing. Because only when you collect your own data, that's going to empower you to then get the care that you need. Okay, so your life stage, right? I think Dr. Michelle talked about this a little bit, but what I really want to focus on is really before you even get into that perimenopausal stage, before you hit 40, right? Because for some women with endometriosis, especially with, chocolate cysts, for example, it can have such an impact on your eggs that, you can go into early menopause. And what happens when you go into early menopause, right? And this is something that, I'm working very hard on, is to educate that, the earlier you go into menopause, the bigger your risk for Alzheimer's disease, heart attacks, right? Cardiovascular disease, osteoporosis, fragility fractures, right? The list goes on and on and on. So my mother, for example, she fell, I think early 70s, fell, broke her hips, and they couldn't operate on her. So she was in excruciating pain. And why? So she had, now she had osteoporosis. They couldn't operate on her because her heart was too weak. So she's in real pain. She was also incontinent, linked to menopause as well, because of that genital urinary syndrome, right? So the client, and then she was really confused. She was scared. So, early stages of dementia, osteoporosis, cardiovascular disease, incontinence, right? We found out that she was also diabetic when she was admitted. All these things, right? If you are able to manage it, if you're able to find out earlier on, before 40, check your egg count. Ask your gynecologist, what's my egg count, right? Because that's then going to help you understand. That's going to help you make sure that you stay healthy when you get older, so that you're not bound to a bed. That's going to be important. So all this just feels really complicated. I complain a lot, right? Because I'm not, sometimes I don't get the care that I need. But, you guys have had it worse, right? Because, we know it takes what? An average of 8 to 10 years for endometriosis to be diagnosed, right? And some women don't get it. Like some women see 20, 50 doctors before they get diagnosed, right? And now you have to track your symptoms, and now you have menopause. So why does it feel like such a burden? So it's not your fault. That's what I want to say. It's not your fault. Right now, it's a system failure. Science and research has been focused on men, even like the initial, research, like just use male mice, right? Look at the drugs, some of the drugs focused on men have been, fast-tracked versus women, right? And just, so the first box you can see, not enough data, too little research on endometriosis in peri and postmenopause. And there's even less if you look at the middle box on data on Asian women as well as low-income women. And because of this lack of data, right, the doctors are not getting trained. That's the issue. Now, the problem with us is that a lot of us, especially for women who are not yet diagnosed for endometriosis, we go through primary care. And that is the critical choking point. Similar for menopausal women. When, let's say if I'm having mood swings or I'm just not feeling well, I go to the GP, to the polyclinic. That's where, we're not getting the diagnosis, the correct diagnosis that we need, because the data is poor. Now, if the data is poor, and what you then need is that you need to come in with your data, with what you track, and I'll give you a template for that, to show them, so that they would then be able to see, oh, okay, maybe this is a lot more, this is more than just a symptom. Instead of the doctor, let's say if I go in for a headache, or if I go in for like brain fog, or just chronic fatigue, if he looks at all my symptoms, he may think, oh, maybe this is more complicated than I thought. Instead of just giving her Panadol for the pain, or just giving her statins for high cholesterol, maybe this deserves a referral to a certain specialist who would be able to treat her better, right? So this is what this is the issue right now, which makes your data and your self-advocacy a lot more important. So let's go into the tools. So I'm going to give you some tools that you can use to be able to take back control and self-advocate. So the first one is a tracking tool, right? If you go into Google Play or Mac Play Store, I don't know what you call that, Mac Play Store, right? There are many apps for you to be able to track your endo symptoms, right? Just and a lot of it is gamified, so it's actually quite fun to do. You just like it's like you tap tap tap, and then that's it. It's really quick to do. The thing is to track it, right? So what's your cycle day, whether you're bleeding, your pain, your symptom, your intensity, and your impact. Now, why is it important to track your symptoms? Because because if you go in, right, without just relying on your memory, like I have done many times, because I'm not as disciplined as I like to be, and I have ADHD, right? So that's my excuse, right? Is that it makes your invisible symptoms visible, right? And sometimes you forget, you don't quite, and those symptoms are actually really important. So that's the first thing. The second thing is that sometimes when you go to a doctor, the doctor may think, oh, she, maybe it was just she's just having a bad day. It's just like, an infection or whatever, right? So it actually shows the scale of the condition to the doctor to make him take it more seriously. And when you show the impact, and this is where it's important for the doctors, if you just tell a doctor, I just have a headache, but if you show the doctor how it has consistently impacted you, then it becomes a lot more concrete for the physician. And more importantly, all that to say, that allows your doctor and you to work with a single source of truth. You know how you feel. You feel really bad. The doctor may not know how you feel because the doctor is only just listening to you, and maybe you may not tell him the complete picture or tell her the complete picture, right? So it allows both of you to work with the single source of truth and the full cluster of the symptoms to show the complexity and the scale. And then it gives the doctor an understanding of the right questions to ask you, to probe further, or whether or not to escalate, right? It helps the doctor. So I have that QR code here, and I'm going to distribute this deck to you later on, right? But if you go into Google App Store, you'll find many apps for you to be able to track your endo symptoms. And then if you want the menopause rating scale, or to track your menopause symptoms, there are many scales as well. I can also make sure that Namira gets that to you. So make your symptoms visible. This is the most important step one, right? And be consistent about it, right? Because sometimes when you go to the doctor, for those of you who are young, they may say, oh, it's endometriosis. You're too young to be in menopause. Then for those of you who are, a bit older, right? They'll say, oh, it's just, menopausal symptoms. Your endo should be resolved by now because, you're no longer making any estrogen, right? Which is not true either way, right? Because, the doctors may not have the information that they need. So they'll help you with issues like this. Tool number 2 is the questions to ask your doctor, right? So, just simple questions, a few examples. The point is, if you have questions, write them down as well so that you don't forget them. It's really important because these questions will make sure that you get the care that you need. The doctor is the expert in the medical field. You are the expert on yourself, right? So make sure that you represent yourself the best way possible. Some questions could be, could my symptoms still be active? Endometriosis and not just menopause, especially if, let's say, your post 55, right? Should I be on HRT? What type is right for me, given my history? Already for women without endometriosis, right? So HRT is the same thing as MRT. MRT that, Dr. Michelle was talking about. It's the same thing, right? It's used interchangeably. Hormone replacement therapy, menopause, I can't remember, menopause hormone therapy, I think, yeah, same thing. For women like me, it's already complicated. For women like you with endometriosis, it's even complicated, right? Because you have endometriosis that thrives on estrogen. So should you be on progesterone only, type of Mirena, etc.? Should you be on something else, right? So it has to be individualized, and that deserves a discussion all by itself. This is a complex discussion. The third one is, how frequently should we be screening my ovaries or lesions for changes, right? My cardiovascular health, bone mineral density, are they being monitored according to my risk profile? And if you don't feel comfortable, or if you feel like the doctor doesn't seem to understand what you need, right? Just advocate for yourself, right? Ask for referral. Let's say if you're talking to your gynae and maybe there are some OGs out there who still don't believe in HRT, right? Then you can say, okay, are there any physicians that you would recommend that specialize in menopause, both menopause and endometriosis, for example? Okay, so I have a slide here on HRT, and what it's saying is that it's not a simple yes or no decision, right? So what you need to consider would be the symptoms, right? Your symptom tracker, the quality of life, your endo history, the type of HRT, your monitoring and review plan, because of your endometriosis. I think the most important thing that you need to ask is that, what benefits can I expect? So that when you're actually on it, let's say post the initial stage where, there'll be a few side effects, let's say after 3 to 6 months, right? What kind of benefits can you expect? So they can actually monitor and see whether it's working, right? And then you also want to have an understanding about, which regimen is safest for you, right? Are there any specific signs that you should look out for? A lot of women, right, and this is on us, right? We don't ask these questions, and then doctors forget to say, because they have KPIs about the number of patients that they need to see, etc., right? So they forget to tell us about the side effects, right? And then we experience the side effects, we stop, and then that's it. And then it's a problem, because then we're not getting the long-term benefit. So ask, right? Are there any side effects that I should be aware of? How long is it going to last? Should I be worried about it? Etc., etc. And then let's say if I'm on this HRT, what happens if my endo flares up? I know I'm supposed to come back and see you, but can you tell me what I can expect? Right? So, think you will have all these questions coming to you when you're lying in bed at night, or, in the shower. Just make sure that you remember them, record them somewhere in your phone or whatever, and then take them to the doctor and ask, right? That's the best thing that you can do for yourself and for the doctor. Tool number 3, right? Because it's complex. Menopause is complex, and endometriosis is even more complex. Build your care team. Good care is made up of more than one doctor, right? So you have your gynecologist with endometriosis experience. Is there, a clinician that's really experienced in menopause, right? Maybe you have mood symptoms, right? So maybe, you're talking with a psychiatrist or a psychologist, right? Are you working with a pelvic floor physiotherapist? Are you working with a pain specialist, etc.? Now, when it's important to have coordinated care, what really frustrated me at the start was that I was getting chopped up into little pieces. My GP wanted to put me on statins. My ortho was just treating me symptomatically, etc. Right. So I think the best approach is that what I found was when you find the doctor, your primary doctor, I think for you guys, it would be your gynecologist, right? Your gynecologist. Ask your gynecologist, for referral. Let's say, if you're having mood symptoms or if you're having, pain symptoms, etc. Ask your gynae to refer you to a specialist, because then, they have that network connection, or they'll be more likely to talk. And why is it important for them to talk? So that they treat your entire condition rather than just the symptoms. And also, let's say, and this is important, especially if you have other conditions as well, that they don't give you drugs that contradict, that are contraindicated against the drugs that you're already on. And this is a real issue. I hear about it quite often. And I just saw it a few weeks ago with my daughter, right? Where, let's say, if you're on an existing drug and you're seeing another doctor, he prescribes you a drug, and that drug is not best friends with the drug that you're on, and then, things go haywire. It will help you with this, right? So make sure that you get the people who are treating you, if possible, to try and, to talk to each other. Because that's going to help you manage your condition a lot better. Okay, so that was really just my real last slide. But before we close, I just wanted to give you a cheat sheet on, just on one slide, everything that you have, right? Just so that you can refer to it, right? Everything here I've already covered earlier on. And that's it. So thank you very much.
Thank you very much, Ms. Diana, for taking us on a comprehensive journey on this topic and how it really impacts like so many aspects of us, right? And of course, for also reminding us about, taking charge of our own, advocating for ourselves, taking note, and the suggestions on also how we can approach, the many different doctors. And I think that's something that's very common that we have so many different doctors and specialists. So I think, thanks for sharing on that. Yeah. Okay, so now we will move into our Q&A segment. And okay, let's see. I will go into Pigeonhole right now. Okay, we have the screen up here. Somebody has kindly put it up there. Hang on, let me just make my... Okay, yep. All right. Okay, so we based it on the upvotes, but I also did take note of some repeat questions, and also some of the topics were addressed by our speakers. But so we will just see how it goes. So the first question is, HRT is often discussed as a way to manage menopause symptoms and support long-term health, especially when menopause happens early. However, for patients with endo or adenomyosis, can HRT worsen symptoms or reactivate disease? If HRT is not suitable, what other options are available to manage menopause symptoms and protect long-term health? I think maybe we can get Dr. Michelle to answer this first. Dr. Michelle is muted. Okay.
Okay, all right, I was trying to unmute myself. Okay, so I think this is a very important question. It is also something that recent guidelines and evidence have given us confidence about the use of MHT or HRT in patients with endo. Traditionally, endometriosis is an estrogen-fed condition. So actually, in the past, we used to be morbidly fearful of giving our patients estrogen for fear of causing more harm. In fact, our patients are also very morbidly fearful because they've gone through a whole life of pain and all of the related chronic types of symptoms. They do not want, as they are transitioning maybe through some debilitating symptoms, but it's always a risk-benefit ratio. But I would like to emphasize and increase awareness that the latest guidelines have shown that MHT is safe, there is this thing called an estrogen threshold level, where beyond a certain level, it will not increase your risks of endometriosis recurrence. But ultimately, it's also not guided by a value. So that's why in terms of principles of MHT, we always start with the lowest, safest, most effective dose, which is why I often start my patients. I'm quite familiar with giving MHT to patients both without endometriosis or patients with endometriosis, but I always try to start with transdermal estrogen. And of course, you assess all of our other pro-thrombotic risk factors, because the only contraindication that we are concerned about for estrogen is about risk of stroke, thrombotic events. So I often start with a low or medium dose transdermal estrogen. But very importantly, okay, the estrogen needs to be counteracted upon with progestins or progesterone. If you give estrogen and you give progesterone, the likelihood of reactivation of the disease is very, very little. And of course, longitudinal care. You don't just give the patients like a 2-year supply of MHT and say, see you in 2 years. I always start with the lowest, safest, most effective dose, and each medications also have their better side effect profile that could be individualized. And so I also start my patients usually on like a 1 to 2 month kind of thing. So I'll say like, okay, I'll just see you again in a month's time or 2 months' time. Not so much to see whether anything bad will happen, just to reassure them. Because if sometimes you tell them, oh, I'll see you in 1 month's time, then like, oh, why, what will happen, you know? No, it's just to say like, allow you to air your grievances, or maybe also just to tell me what your experience was. And actually something very important is to emphasize the compliance, because a lot of times when I start my patients on hormone treatments, it doesn't have to be MHT, even contraceptive pills, they take it for 1 to 2 months, get a lot of side effects, which we know sometimes can happen in the first 1 to 2 months. And then they're like, I don't want to go back and see the doctor anymore because, you know, she gave me a year's supply and 2 months in this, you know, my symptoms are worse than ever. Or sometimes they just get worried across time if they hear people saying that there are risks of cancer, etc. So for me, okay, I think it is important to emphasize that even if you have endometriosis, you can take MHT. The second very important thing I will say is that it's different from treatment of premature menopause or premature ovarian insufficiency is different from treating symptoms of menopause, right? Because in premature ovarian insufficiency, you need the replacement. Otherwise, all of the impacts are going to be a lot worse. I recently had a patient with premature ovarian insufficiency at the age of 41, and fortunately, she took a bit of time to present to me, and when we did a BMD for her, she's already osteopenic to almost an osteoporotic level. Whether or not earlier treatment when started for her could have prevented this, we can't say, but I think it would have been not as bad as the situation now. Another type of hormone treatment, sorry to go on a little bit, is tibolone. I think I mentioned it in my talk earlier. It's a synthetic type of progestin, a synthetic type of hormone that actually evidence shows that has a slightly lower chance of reactivating endometriosis. So that is an option that I consider for my patients too. And it's very good effects in terms of the symptoms of menopause, especially for sexual health.
Okay. So Ms. Diana, would you like to add anything, or we move on to the next question?
No, I think that's a medical question and should be handled by
All
Dr.
right,
Michelle.
okay. Sure. So I think the next one is also a medical question. So Dr. Michelle, maybe you could speak on the questions out there. Do you need me to read it, or maybe you can just
Yeah, I think I'll just read it so that everyone can. So since hysterectomy is considered the permanent cure for adenomyosis, or when a partial hysterectomy or full, also if hysterectomy leads to early menopause, what are the long-term? I see. Okay, so actually, in modern surgical treatment of adenomyosis, firstly, medical treatment usually is started first because you want to weigh the surgical risk with the impacts of the treatment outcomes. But when surgery is indicated, nowadays we perform total hysterectomies. So in the past, there was some evidence or confusion about whether removal of the whole uterus, which includes the cervix. So the cervix, just to give some explanation, is the opening of the uterus. Actually, it's all joined together, okay? But in the past, okay, there was something called a subtotal hysterectomy where you only remove the top part which is just the uterus leaving the cervix behind, because there were some studies that said that sexual health or sexual function were impaired if you removed the cervix, as well as risks of some urinary incontinence. But later studies actually show no such thing. So actually these days, whenever we talk about a hysterectomy, we are talking about a total hysterectomy, which includes the cervix. And actually there's no bearing in terms of the impact of adenomyosis. We just routinely remove the whole uterus, including the cervix. I think the concern that we are talking about over here actually, or a slight confusion, is whether or not we remove the ovaries at the same time. So the uterus is a completely structural organ. It does not usually get involved in ovulation and the production of hormones. Very slight, but unlikely. So whenever we talk about removal of the uterus or hysterectomy, we are not talking about concomitant removal of the ovaries. So actually, if you remove the uterus, it might not lead to early menopause, except that you will not have your periods anymore. But this is also an important discussion because a lot of patients with adenomyosis also have concomitant endometriosis. So when you're addressing the symptoms of the patient, especially pain, it is important that your gynecologist addresses the fact that sometimes endometriosis that is in the ovaries or in the pelvis, removal of the uterus alone might not eliminate the pain. So actually for a hysterectomy in terms of adenomyosis, it's definitely effective for helping with heavy bleeding, which a lot of patients with adenomyosis suffer from.
Okay, let's move to the next question then. Okay, so can perimenopause cause symptoms beyond periods and hot flashes, such as sudden skin rashes, ringing ears? Blood work, medical checkup are normal, experiencing strange changes, would like to understand whether hormones could play a role and what red flags would suggest something else needs to be investigated. Perhaps I can request Ms. Diana to maybe speak briefly on this, and then we could move on to Dr. Michelle if she has anything else to add.
I think it'll be good for Dr. Michelle to give the scientific view and for me to give the
lived experience.
what I feel. Right. So the symptoms for perimenopause and menopause, they are so random and so generic, right? That sometimes I just wonder, like, what is happening? What we need to understand is that there are estrogen receptors throughout our entire body. So everything can be impacted, right? So some of the really strange symptoms that I'm experiencing, for example, is that I will smell random smells. I was just talking to two doctors the other day, and I was describing my symptoms to them, and they're saying, actually, you may have burning mouth syndrome that's also associated with menopause. I'm starting to see shadows on the side of my eyes. Just diagnosed with glaucoma and mild hearing loss. High cholesterol, that's very, very common. High cholesterol, blood pressure goes up. Just can't think as clearly as you can. So I gave you the examples just now, right? Where, just reading, instead of reading normally, I would have to take my mouse and highlight line by line, just so that brain fog, it was a big issue for me. Or joint aches and pains, big thing. Okay, so if I were to look at the data, right, what comes up most frequently for Asian women, Chinese women, and Asian women in general is joint aches and pains, muscle pains, right? That's the big thing. Incontinence, you'll start to feel less, able to control. Hot flashes, yes, cold sweats. Okay, so this is also really random. I found this really, really strange. And this only started happening during perimenopause. Just before my period, one day before, I'll start getting a mild fever. And when I get my period, it'll be gone. It's like, what's happening? Right? So it's super random and it's not attributable. You go and look up, if you look at proper publication, you won't find those symptoms there.
Yeah.
Over to you, Dr. Michelle.
Actually, all these symptoms sound quite typical of the perimenopause or climacteric. I mean, honestly, on a day-to-day basis, actually what heartens me is a lot of people are coming up to tell me about these symptoms. And sometimes they're so embarrassed. They'll come and they'll be like, I know maybe I'm crazy, or like, I'm not sure whether this is related at all to your expertise. You know, we always apologize first. And then we will start saying like, but recently I've been experiencing this and that, and expecting me to be like, no lah, then ringing in the ears cannot be related to menopause. But actually it can be. So actually all these hormone fluctuations cause a, systemic change in our body. I will say a lot of the commoner symptoms like the mood, the flashes, the joint aches, the dryness, insomnia, I'm suffering it myself, literally waking up at 3 in the morning every single day and being unable to fall asleep. So I'm very passionate about these discussions with my patient, frankly, because I'm going through it myself, and it's probably only going to get better. So I've gone through a lot of research and like supplementary types of treatments too, which I'm happy to share as long as there's no risk. So I definitely feel that skin rashes and ringing in ears can be related to the climacteric. But I think as a doctor, what's very important for me to say is that we need to make sure that we're not missing anything else out. So usually when I listen to my patients, I will ask questions about other systemic symptoms or any clues as to their medical history, do a check, and then definitely make sure to rule out nothing more serious is going on before I then commiserate or I give them some form of like advice. Okay, I never say like, oh, it's just like that, nothing we can do about it. There's so many things we can do about, and sometimes just letting patients know that there are some things we can try is already treatment itself. If you tell someone that there's nothing you can do to improve your situation, that is definitely the way to go. And everyone is going to leave the clinic feeling more miserable than ever. But of course, if I say like, I try these supplements, I also have like a bit of brain fog here and there. So I take certain supplements too. Then I'll say, okay, I don't know whether it works for you, but it works for me. And why don't you try it? It's not a risky thing. So you can just get it offline or something, because I don't even sell it, you know what I mean? Yeah, so I think importantly in these situations is empathizing, recognizing that a whole myriad of symptoms can happen. But I think as a medical professional, I will try to make sure to screen through the symptoms, especially for tinnitus. You might be missing something in the inner ear. So I might, if there are other symptoms going on, headache or migraine or something, I might get them to see an ENT first. But meanwhile, if they have enough symptoms, I might consider starting them on some low-dose MHT to see if there's improvement if they've already tried exercise and lifestyle means, like transdermal estrogel with some utrogestin or micronized progesterone. It's not going to harm anyone if they have no contraindications. Another thing I want to say is that actually for MHT, there are so many different types that subtle differences can help different symptoms. So for sleep, actually, micronized progesterones or utrogestins are like super effective. So while we used to give them in pregnancy and patients will say we feel so sleepy, conversely, in MHT, it enacts a very pleasant side effect.
Okay, thank you for that. So the next question. Okay, this one directly to Ms. Diana. Caregivers, partners, family members, how can they better support someone going through hormonal changes?
I think the most important thing first, and this is something that I believe, is that we feel, first of all, it starts with the woman, right? The woman needs to understand herself and understand what is it that she needs. Some of the, when women talk to me about, the experience, a lot of times there is this, I'm going to grit through it, my father swam all the way from China to Singapore, and I'm expected to do the same. So they need to be aware first that they need help, right? And then once once we accept that, okay, I need help, right? I am maybe struggling in this and that, then immediately you realize, okay, this is the help I need from them. So for my daughter, for example, I tell her, right, I'm not going to make, I just told her this week, because I haven't been sleeping. I've been sleeping 3 to 4 hours this entire week, and I'm dead. Right? I said, I'm not going to make breakfast for you this entire week. You have to deal with it yourself. Right. And then, I divorced my husband, so I don't talk to him anymore. Right. Or, like household chores, or, let's say at work, right? Having a discussion with someone that you trust. If you feel like your manager won't understand and will dismiss you, it's a different story. If your manager is trustworthy, maybe ask for hybrid work. That has worked wonders for me. Being able to go back to my bed and lie down for half an hour when I'm just not, the chronic fatigue that comes with menopause, it's horrible, right? But being able to lie down for 30 minutes in bed and then come back and work as miracles. So once we are aware and understand that we need help, then the woman can because if you try and offer help to a woman who believes that she can manage it all, you may get rebuffed. Yeah, there may be issues there.
Okay, so I do notice that we have gone slightly over time, but I mean, if Dr. Michelle and Ms. Diana, if you're okay with it, with your kind permission, would it be all right if we extend it to say for another five minutes or 10 minutes to answer more questions? All right, let's move to the next question then. Okay. How can patients speak for themselves during consultations without feeling overwhelmed or dismissed? I know that you had a section on speaking to doctors, so I think that was quite thorough, but is there anything you just want to briefly add on here?
First of all, it's normal, right? It depends on which doctor you see. Because it also you feed off the energy of the doctor. That's really important. So I get overwhelmed, and I got dismissed. My co-founder for Menopause Care Alliance, I think she had a GP who told her to go and pray, right? So it's normal to feel, because you're in there, you've got like 5 minutes, and then you're supposed to tell everything, and then you can't remember anything because your brain is gone and you haven't been sleeping, right? You have a fever or whatever. So it's normal to feel overwhelmed. So how do you deal with that? Record things down, write things down, write your questions down so that you are already prepared. A good appointment happens before the appointment. The second thing to know, and this has helped me tremendously, is to also realize that doctors are just people like you. They're having good days, they're having bad days, right? And medicine is such a huge field, right? You can't expect a doctor to be trained in everything. Then they'd be like, AI robots, right? So your doctor is probably a specialist in something. GPs are specialists in chronic care, chronic diseases, right? This doctor is specialist in that. So the idea here is to make sure that you go in, ask the questions that you need, and the doctor's not the right person for you. You don't like his vibe, or he's not the specialist you need. Because you have prepared those questions, you have the data, it'll be clear, and then you just like, okay, thank you, that was great, and then you just move on to the next one.
Okay. Next question, please. Does every hysterectomy lead to menopause or only when the ovaries? Okay, I think earlier, Dr. Michelle did briefly talk about it. So let me just see. In this one, other negative impacts such as breast cancer. So I think it's a bit of a morbidity rather question. Dr. Michelle, do you want to say anything about it?
No problem. Generally speaking, MHT and hormone treatment is very, very safe. It does not cause an increased risk of breast cancer. But in patients with existing breast conditions or breast cancer that are hormone receptor positive, it is a contraindication. Having said that, the low dose estrogen via any topical preparation, generally like inserts in the vagina, gels or patches, the systemic absorption is pretty low. So I would say generally it's safe. At the end of the day, it is a risk-benefit ratio. And as long as you monitor, there shouldn't be any problems at all. Of course, another thing will be like routine and timely breast cancer screening. So I always make sure my patients are up to date with their mammograms, with their 3D ultrasound breasts, and especially if they have any lumps, and advise them on self-breast examinations. And sometimes if they're okay, I'll do a breast examination myself.
Okay, thank you for that. Next question. Okay, on to another topic, BMD, right? Bone density. So how do we maintain it?
I mean, in terms of, if you don't mind, Diana, I'll just go first. Okay, so how to maintain BMD? I think for sure we need to ensure that our diet has enough calcium, that we are getting sun exposure, we are doing some form of strength training. I will say that actually nowadays my patients are very informed and they all are into strength training. I'm very surprised. That day I had this 70-year-old lady come to see me and then she was like, oh, when can I go back to strength training? I was like, better than me. I'm impressed.
Excellent.
So yeah, so it's good. I think that's important. Whether or not weightlifting activity triggers pelvic floor hypertonicity. To my knowledge, okay, no. I think everything that is never going to be 100% is going to cause a problem or is never going to cause a problem. So I think if you do the training appropriately and if you're unsure, you can engage a trainer or speak to a physiotherapist. There shouldn't be any reason why weightlifting causes worsening of pelvic floor tone.
Okay. Miss Diana, you wanted to add something?
Yeah, so I'm very passionate about bone health. So Menopause Care Alliance launched a public education and screening program for bone health, right? And my mother and my father-in-law, and I see lots of people around me basically dying because of fragility fractures, right? Or not getting the care that they need. So we launched this program. So I think the first thing, the bad news, right? And maybe this is for the younger people. So if you're, let's say, in your 20s or your 30s, right, make sure that you get your calcium stores, because it's still up, right? But when you're, let's say, in your late 40s, your 50s, your ability to add to add significantly to your bone density, decreases significantly. But you still can do some things, right? Nutrition, like make sure really basic things. When you go to a supermarket and buying your stuff, you just like, if you cannot see properly, take a picture and then zoom to see what's the calcium content, right? Make sure that you do, swaps. Like sardines are great for calcium. Do food swaps. It's like zero effort, right? Zero cost. So we actually did 2 micro-learning modules. So like TikTok style, you go on Instagram Reels, 2 minutes each, right? I'll get Namira to send you out the QR codes. Sure win vouchers. You get like free vouchers for Centrium, right? Discount vouchers. You learn how to what are the swaps that you can do, how to make sure, how to know, what are your risk factors, right? What you can do to be able to manage bone health, what you can talk to your doctor about it. So I'll send you the resources so that you can enjoy.
Okay. All right. And the next question. Okay. Yeah, we did touch on this, but I think some of us are, still a bit confused because we've heard differing information, right? So,
I'll
yeah.
let Dr. Michelle take it.
Okay, yeah, Dr. Michelle. So, after menopause, does endometriosis, is that no longer a factor and does it disappear?
I think when we're talking about disappearing, we differentiate it between symptoms versus the actual disease itself. So in terms of symptoms, thankfully, a lot of patients, because the endometriotic lesions are being fed by estrogen, a lot of patients, as they transition into menopause, truthfully, their symptoms do improve significantly. But we can't say 100%. There are actually lots of reports of endometriosis symptoms persisting through the climacteric and into the menopause, which is why sometimes there is an overlap of symptoms and patients find it difficult to differentiate. There is also an entity of postmenopausal endometriosis. That means de novo, brand new endometriosis after menopause. There are such reports around as well. And the postulation is actually because we still have estrogen produced by our fat tissues and other tissues in our body as well. So I won't tell my patients that endometriosis will disappear, but I will say that as we transition, a lot of us, it's also good to give hope, right? A lot of us will have symptoms that may improve with time, but we can just continue to see how it feels. But also, if they do continue to have symptoms, hormone treatments that are targeted towards endometriosis pain, things like the Denorgestrel or Visane, things like levonorgestrel IUD or the Mirena, increasingly are known to be very safe to continue all the way up till we hit menopause. So I have patients that actually are so frightful of stopping the Denorgestrel or Visane because even if they are, almost at the age of 50, because then they'll tell me my mom had menopause pretty late. I don't want to have that situation where every month I'm undergoing that kind of pain again anymore. And actually, I'm okay with them being on the medications because actually there's good evidence to say that unless we have contraindications, which are few and far between, as long as you keep yourself in longitudinal care, make sure you keep coming back for follow-up, maybe on a semi-annual or annual basis, so that I make sure everything is okay. We can continue to be on medications, even if the symptoms don't disappear after menopause.
Okay. So I think that thank you for the answers, Dr. Michelle and Ms. Diana. I think we will have to end the Q&A session at the moment. It has really been, I think, very informative, and thank you to everyone for submitting your questions as well. And for joining us live and listening and choosing to spend your Saturday afternoon, with us. Today's topic, well, is not easy to talk about. So, but conversations like this, I think, really help to bring light into all these areas that many of us are navigating, quietly. So, so at E for Endometriosis, we believe that education should be accessible and that people deserve to understand their bodies, their options, their care journey with more clarity and confidence. This session will be available on our YouTube channel, so please feel free to revisit whenever you need a refresher and share it with someone who may benefit from the knowledge. Yeah, we have all the social media accounts right now up there on the screen, so you can take note of that. And we will be having our next quarterly Zoom session on 25th July, and that's on the topic of endometriosis and its comorbidities. So yeah, do sign up for it when registrations open. And so that's all for now. Thank you so much once again to our speakers and to everyone who joined us. Thank you and have a lovely rest of the weekend ahead.